Guys, I cannot catch a break. Apologies that this had to be in 2 recordings. We lost internet during my last recording. So back today, coming back with the kind of second half of this first PowerPoint. So you'll have a lot of recordings for this module. So we were talking about how do we interpret those bypass graphs, what is considered normal versus abnormal, since we're kind of doing this like potentially artificial pathway for the arterial flow. So we had previously mentioned that normal evaluation or interpretation of bypass graph is going to be as close to a normal arterial waveform as possible. So we want to see triphasic waveforms. We want to see a nice clear spectral window. We don't want to see any spectral broadening. We don't want to see any kind of weak peak systolic velocities. So pretty much as close to a normal arterial pulse as possible is going to be considered normal. Now, a lot of these patients are going to be coming in for a lot of routine follow-ups if they have a bypass graft. So we may see them every 6 months. We may see them every year, maybe every 2 years. We definitely see them if they have to get their graft replaced at any point. Grafts don't last forever, so sometimes we have to go in and replace them. So really, we're seeing these patients quite a bit. So when we're looking at these, we want to make sure that we have as many priors as possible, and we're really looking to see if there are any changes, especially in those waveforms and those velocities. So any decrease within any segment of the graft in and of itself, so not the inflow or the outflow vessel, within the graft itself. So from proximal anastomosis all the way through that graft to distal anastomosis. If we see a decrease of anything 30 centimeters per second or more, automatically abnormal. Also, if we see weakened peak systolic velocities in the smallest diameter of the graft that was previously a higher velocity, that's going to be abnormal. So we're really looking and making sure that the smallest areas or the most narrow diameters of where that graft is placed are operating to its fullest potential. Any change in triphasic waveforms to biphasic flow is going to kind of be like that gray area of being abnormal. So how old is this graft? How old is this patient? What else is going on? If this graft is old, maybe they're getting ready to replace it, we could typically see triphasic flow go to biphasic flow. It's still considered abnormal, but it's less severe if we see biphasic flow without a decrease in peak systolic velocity. So if the velocity is still the same from a previous study, but the only thing that changed was it was previously triphasic flow and now it's biphasic flow, we're not as concerned because the velocity is still appropriate for what it was and what it should be. Now we're also looking for any kind of post-surgical complications, so an abnormal AV fistula, any kind of perigraft fluid like we had previously mentioned, any kind of puncture to the inflow or the outflow vessel. And then we're really using as much previous information as we can about that arterial disease prior to the bypass graft placement. So we want to make sure we have a good understanding of why the patient needed this, how severe it was before, like what was the cause of this patient needing a bypass graft, so we can, make sure we're doing the best evaluation possible. So moving into lower extremity. So those grafts, again, like we said, we're usually going to be using a bypass graft for patients who are really sick. So cancer patients, dialysis patients. So we're using a lot of arm evaluation for bypass grafts, but we're definitely still using especially those in situ bypass grafts or the synthetic bypass grafts down in the patient's arterial legs. So just because we kind of grouped in the bypass information with the upper extremity, it's just because we see a lot of bypass grafts for dialysis patients. So it's kind of why it's in that upper extremity category, but still kind of same evaluation and interpretation process with the lower extremity if we were to see a bypass graft down there. So if we are doing an arterial leg exam, we really want our patient to be NPO for at least 8 hours. And that's because we're not just starting at their legs, we're starting at their aorta. So we need to make sure we're giving a good evaluation of the aorta. We want to make sure that the patient is supine with the extremities at the same level as the heart. And we kind of want to let them lay there for a minute before we start our exam. You want your patient's heart to kind of relax. You want those contractions to kind of slow down a little bit so that we're not getting these abnormally elevated velocities from that patient having quote unquote exercised as they walked from the waiting room to your exam room. So let them lay there for a second, make sure they're comfortable. We want to make sure that their hips are externally rotated and their knees are slightly bent, so they're laying in a frog position if they can. We are going to be using our curve transducer for the abdominal portion, and then we're going to switch to our vascular probe for the rest of the leg portion. And we're doing the same thing as we typically would for a regular aorta, but we're just taking that all the way down the legs. So we're doing grayscale, color, and Doppler. Of course, we're not going to be doing any compression because we're talking about the arterial system. So what is our standard protocol for doing an arterial leg? We need to be looking at the aorta, especially the distal portion of it. So we want to be evaluating that bifurcation really well, making sure that the entire aorta is good. There's no aneurysms, there's nothing crazy going on, there's no obvious dissection that we can see, but we want to put emphasis on that distal region at the bifurcation. Typically, when we're doing an arterial leg, we're usually going to be doing both legs because if you have arterial disease in one leg, it's highly likely that you have it in both. So we're usually doing a bilateral lower extremity arterial exam. So we're really kind of focusing in on that bifurcation, moving down to typically starting on the right leg, that common iliac artery, right common iliac artery. We're also kind of following that down a little bit further now, getting closer towards that inguinal canal for the external iliac artery. Remember the internal iliac artery, that other branch of the common iliac artery, also known as the hypogastric arteries from our quiz. That is going to be something that we don't really see, especially in patients who are bigger. So we're not really worrying about that internal iliac artery. So our common iliac artery is going to come down into our external iliac artery, coming down now into the leg to the common femoral artery. And now we're going to kind of follow that same anatomic process that we do with the venous leg. So common femoral artery to femoral artery, proximate distal to our popliteal artery. We also have our profunda artery that we look at in that proximal region where that common femoral and that, quote unquote superficial, although I don't like that word, femoral artery are going to split. We're also going to see the profunda femoral artery there, all the way down to the pop artery, and then we're going to see our calf arteries. So we have proximate distal PTA that we have to evaluate. Same thing with our ATA, so proximate distal with that. Our perineal artery, sometimes we can't get proximate distal, but it's really important for us to try our best. So PTA and ATA, proximate distal, are absolutely necessary. And then our pero artery is going to be something that we should be trying our best for. We're doing peak systolic velocity measurements and end diastolic velocity measurements on all of these Dopplers. Every single proximate distal of all of these vessels, we are getting a peak systolic. We also want an end diastolic, but it's not necessarily as important or as useful as the peak systolic is. We want to make sure that we are getting multiple waveforms, multiple PSVs, in any area that we are suspecting that there's disease present. So if all of a sudden you're scanning down somebody's leg and you see like a massive chunk of plaque hanging out in one of these segments, you want to be taking multiple waveforms of that segment. You want to be taking multiple peak velocities of that segment to really kind of see an average of what is going on in that region. We also want to make sure we're characterizing our Doppler signals, so we're looking to see if there's spectral broadening, if there's any turbulence, if there's flattened or weakened waveforms, right? We wouldn't expect to see flattened or weakened waveforms right in the meat and potatoes of a stenosis, but we can see flattened waveforms prior to and after a stenosis. If we are suspecting a diameter reduction of more than 50%, so that diameter of that segment of the vessel is now cut in half, you really want to make sure you're evaluating it before that diameter reduction occurred. within that diameter reduction, and after that diameter reduction. So the pre-stenotic, meaning sampling that peak systolic velocity before the area of the stenosis. And then also we want to make sure we're getting the highest velocity within the stenosis itself. So we're usually going to see a little bit of a weakened waveform prior to the stenosis, and then right within it, right where it's going to be the most narrow, should be where we get our highest velocity. So kind of just going through, we know how we should be scanning an aorta. We know what we're looking at. With this, like we said, we're taking it down further into the legs. So we really want to make sure we're doing a good evaluation of the right common iliac and the left common iliac from that bifurcation. We're still looking for aneurysms. We're still looking for dissections. We know how to document those things. We know how to document a AAA or an aneurysm of any type. So we're following what we know, and then we're taking it a step further down into the leg. So here we kind of have our standard inguinal region of where we're looking at these vessels in the legs. So we have our common femoral. If we come up higher, if we were to scan up higher, especially in this picture here to the right, this region would be our external iliac. And we can kind of tell because this right here is the hip joint. So that bone right there is basically saying, hey, here is where my pelvis meets my leg. You know that if you're higher up above that hip joint, that's going to be your external iliac artery. As you're coming down, you're kind of right over that hip joint. That's going to be your common femoral artery. And then we know down distally from that, we're going to see our superficial femoral artery go all the way down the leg. And we're going to see that profunda artery come off in that same region and dive a little bit deeper in that proximal area. Following that down, so we've now followed our femoral artery from proximate distal. We're now in the popliteal region at the back of the patient's leg. Same thing, we're still evaluating that just like how we do with a vein. We're going behind that patient's knee with the kind of acronym of the venous imaging where you have pop on top. That's how you can kind of tell when you are doing the popliteal artery versus vein. Typically, when you're doing a DVT study, so a venous leg, a lot of the arteries sit higher than the vein when you're doing your compression or your sag. The popliteal vein flips. So when you hear people reference pop on top, it's talking about the popliteal vein is on top of the popliteal artery. So in this case, remember, when you're doing an arterial leg, your popliteal artery is going to be below your popliteal vein. Also, we want to spend a little bit more time back here because we want to make sure we see the junction of where those calf vessels are coming off. It's a little bit easier because it's the arterial system, so we don't really have to worry about like getting them to fill. Arteries are typically easier for us to find than veins are, especially calf arteries versus calf veins. So we need to spend a little bit more time in this posterior knee region to see where our ATA is going to come off, where our tibioperineal trunk is going to be, right? Because we know our ATA is going to come off before the tibioperineal trunk. Tibioperineal trunk is going to split off from itself a little bit lower down. So in this picture, we have our distal pop artery. We see our ATA coming off first. This is our tibioperineal trunk, and somewhere in this region, we would see our perineal artery and our posterior tibial artery come off that little trunk region. And same thing, color, Dopplering, getting a peak systolic of all those segments. So now kind of looking at these calf arteries more so in the calf region, we want to make sure that we are aware of our anatomy. So if we're looking on the anterior aspect of a patient's calf, we know that we're trying to be looking for the anterior tibial artery, but we don't want to just look right on top of the patient's bone. You want to go a little bit more laterally so that you're kind of elongated between the patient's fibula and tibia. Remember, the tibia is the big calf bone that goes right down the middle. Our fibula sits on the outside of that tibia, so on the lateral aspects of our calves. So we want to be kind of in that lateral groove from that anterior approach. When we're looking kind of in the meat of the patient's calf, so the medial aspect of the patient's calf, medial to the tibia, that's where we're going to see our PTA and our para A. These vessels are small. And remember, we're talking about patients who have arterial disease. So when you guys are scanning each other in lab, these arteries are going to kind of like light up like a beautiful Christmas tree. But when you're doing a real patient in clinic, these patients have arterial disease. So they're either going to be filled with plaque, or they're going to have really thick walls that make the lumen really small, or they may be really large patients. So you can't work through all of that soft tissue to get a good evaluation of the artery. So make sure you're taking your time. Although the arteries are a little bit easier to find than the calf veins are, you still have to take more pictures of the calf arteries than we do of the calf veins. Calf veins, we kind of do a compression, a sag, a color, a Doppler, call it a day. These you have to now add in the ATA, whereas on a regular venous leg, we don't do the ATVs. So arterial leg, we're adding in the ATA, and we're looking at the ATA, the PTA, and the pero, all prox, mid, and distal. And then even once we have that, we're still not done. We still have to go and evaluate the DPA at the top of the patient's foot. So there's more that goes into it. It's a little bit technically easier for you to find the arteries, but there's more that you have to do for these exams. So make sure you're taking your time and you have a good understanding of where your anatomy is going to be. Because if you're looking all over the place, here, there, everywhere, you're never going to find it. It's going to be really hard for you to confidently say, here is this segment of this artery, and it looks good, or it doesn't look good, especially when arterial disease is involved in these patients. The other thing on here, we should be aware of what the medial malleolus means. We have talked about this before in some previous lectures, but if we're talking about our ankle, so if we look at our ankles, we kind of have these two little balls that stick out on the inside and the outside of our ankles. Typically the little ball on the outside of our ankle that's more prominent, that's going to be our lateral malleolus. Remember, we learned that when we were talking about the plantar arches. So the medial malleolus is going to be that ball that kind of sits a little bit smaller, a little less, protrudy on the inside of our ankles. And that was a nice picture showing our PTA and our Pero A with the calf veins going around it. So how do we evaluate a stenosis? So one of the first things that can draw our eye while we're just scanning, kind of getting the lay of the land, is going to be plaque. So plaque typically will jump out at us, especially if it's focal plaque, but sometimes we can have patients who have diffuse atherosclerosis, and that makes our job harder because the plaque is small. It kind of like layers along the walls of the arteries, and it kind of makes the vessel itself blend into the surrounding soft tissue. So we actually can't even really see the vessel. So plaque is really not our friend, especially in the legs. We also know that plaque is going to attribute to increased velocity. So we're going to start to see a mosaic pattern when we're using our color Doppler. We're not going to get a nice, pretty red waveform. We're going to see things kind of getting a little bit more chaotic. We want to be characterizing the Doppler signal in the areas where we see plaque. So if we have diffuse moderate plaque, well, we're probably not going to see a beautiful triphasic waveform. We're probably going to see something more biphasic. We're also going to start to see some spectral broadening when we have a stenosis or any kind of abnormality in that vessel. So severity of a stenosis, regardless of what it's caused from, we're going to see changes in the waveform, phasicity, we're going to start to see spectral broadening, we're going to see changes in the velocity, typically going to increase in the area of where the stenosis is occurring. And we also want to make sure that when we see a stenosis and we see those characteristics, that we're looking at the vessel before the stenosis and after the stenosis. So if we're not seeing any detectable flow in a vessel, say we see a vessel, we see, we're talking about the calf veins here. We see nice, beautiful calf veins. We know that we should see the calf artery between the calf veins, and I'm not really seeing anything. I'm kind of seeing the elongated tube of where that artery should be, but I'm not getting it to fill with flow. I'm not getting any waveform when I Doppler it. That's going to be indicative that there's going to be some kind of occlusion in that area. Now, when we have an occlusion, we don't want to just kind of call it a day. We want to still evaluate it. We still want to prove that it's occluded. We want to show that there's no color flow, that there's no waveform when we Doppler it, but we're also going to be looking to see if there's any obvious collateral pathway that formed in response to that occlusion. So we're looking around, we're kind of problem solving, seeing where that blood is being rerouted to. And how do we interpret a stenosis specifically? So normal blood vessel. We've said this 1,000 times, triphasic waveform. We know that some normal patients can have a biphasic waveform without having any disease present. So if you see a triphasic waveform and you see a peak velocity of, 115 centimeters per second, beautiful, nice, normal, healthy vessel. If you see a biphasic waveform, no spectral broadening, no mosaic pattern of the color, everything looks good with color evaluation, you go to Doppler it, it's 120 centimeters per second, still beautiful, perfect, normal. We're not going to bother with it. If you see a biphasic waveform and you're starting to maybe see a little bit of that mosaic pattern with color and your peak systolic velocity in that area is like 130, that's when we're going to start to kind of question some abnormalities happening. So you have to take it on a case-by-case basis and look at what all of the information that you are obtaining is providing to you. All of that information is helping you to determine if there truly is arterial disease in that patient. So anything that's always going to be abnormal is going to be when we have really significant ratio differences. So when we are comparing a velocity that we are obtaining in a stenosis with the velocity that we are obtaining before the stenosis. So say you're going along with your day, you're kind of scanning right down that patient's leg, and all of a sudden you get to a mid-region of a segment and you get a waveform that is 418 centimeters per second. Okay, well, that's ridiculous, right? That's really, really high. We don't want to see anything higher than 125. And then you go to Doppler right before you got the region of where you got that really, really high velocity. You are going to use those two velocities to help you calculate a ratio. So if we have a 2-to-1 ratio, that's going to indicate that there is at least a 50% diameter reduction in that segment of that vessel where you got that really, really high velocity. If you have a 4-to-1 ratio, so if that pre-stenotic turbulent or pre-stenotic, if that true stenotic PSV is 4 times greater than where you obtained the pre-stenotic PSV, you are going to indicate that there is at least a 75% diameter reduction in that segment of where you got that really, really high PSV. Anytime we also see anything greater than 400, we automatically know that that's going to be at least 75% diameter reduction, because that's automatically going to be at least 4 times greater than any of the other normal velocities that you got prior to that area. We should be seeing post-stenotic turbulence with pretty much anything in that, 50 to 75 to 90 to 99% diameter reduction stenosis. I say 99% because if something is occluded, then that means there's no blood flow getting through it. So that means that's it. There's nothing. So there's no really high velocity, there's no diameter reduction, there's no color turbulence, there's nothing, because there's literally no flow getting through that region. So, anything from 50% diameter reduced to 99% diameter reduced, we're going to see some post-stenotic turbulence. We also want to make sure that we're evaluating for occlusions and aneurysms in response to really tight stenoses. Stenoses. I really don't know. So again, I apologize. 2 recordings for this PowerPoint. We are going to, in this module, also be talking about intra-abdominal arterial evaluation. So kind of categorize these things as you see fit. Pretty standard in terms of the technical protocol of doing an arterial leg. We should be familiar with this anatomy. There's some slight differences between the venous and the arterial evaluation and interpretation, but really make sure you're understanding the new information from these PowerPoints. Make sure you understand graphs. Make sure you understand the difference between an AV graft versus an AVM, right? An arterial venous malformation. Make sure you understand how we evaluate a stenosis and what all of these numbers mean in terms of scanning. So we're going to kind of roll into our intra-abdominal arterial recording, but if you have any questions, please ask.